Well, hi everyone. Appreciate you being here with us this morning. If you haven't met me in another context, my name is Luke Todd. I'm a policy analyst with the Medicaid fee-for-service behavioral health team, and been working on this billing guide for MCIS and stabilization services for a while now. I know some of you have had a chance to weigh in on prior versions of this, and I appreciate that. So hopefully we've addressed some of those questions up front in this final version, as well as an FAQ document that we've put together. Beth has dropped those in the chat because I know that they weren't finished. I wasn't able to get them out to all of you with a lot of opportunity to review, but if you want to pull them up and look at them as we're going along, that is just fine. In terms of the content today, this is, and Brian, you can go ahead to the next slide. This is really just a summary of what's in the billing guide, but at the same time, it's not quite as comprehensive as what's there. As a result, like, I'd prefer you guys refer to the billing guide and FAQ to rule rather than using this on its own for training or billing purposes. You can certainly refer to it, but we just want to make sure we're always referring back to sort of those official sources, which is the rules and sub-regulatory guidance that we publish. And then those, of course, are always subject to change. So just looking at this or prior versions like the one that Beth attached, make sure you're always using the most up-to-date one. After this session, later this week, we will get the billing guide and FAQ document published online, and those will be the official documents. Okay, those don't seem to be going in quite right. As we can troubleshoot getting those attachments in if you're not able to sort it out, but appreciate you working on it. Let's see here. Yeah, I think that's all I needed to say. Oh, by way of questions, feel free to put your questions in the chat or to raise your hand and just jump in with questions along the way. I do want to avoid, where I can, answering non-billing questions. I know program issues and billing issues are, closely connected. And we do have some program folks here. So if you have those questions as it relates to billing, we can get them answered by the right people. But also for like licensing and certification questions, we just may have to defer those until the appropriate person can answer them. If that person isn't here, we'll make sure to get back to you in writing. Yeah. Let's. I also, just by way of, there are several things, if you've seen prior versions of this, several things in the billing guide itself that have changed. I'll try to highlight those as we come across them, just for those of you that have seen the prior versions. And if a question comes up that I have addressed in the FAQ, I may pull that up and just kind of point to that so that you all can get familiar with what's there. My intent after we're done with this is to publish the billing guide largely as it is. And then as additional, again, unless someone notices an error or something that's legitimately problematic or confusing. But then we'll plan to have the FAQ as more of a living document that will update more regularly as you all continue to work with the billing guide as it stands, and have ongoing updates there on a more regular basis. So, all right, next slide, Brian. All right. Starting just by mentioning these reimbursement rates up front, and this is for all mobile crisis services, including MCIS, which is the new standard of mobile crisis that you all are working on standing up, as well as the old standard of mobile crisis. You'll see the difference in rates there. They're both going to be billed with H2011, which is crisis intervention services per 15 minutes. Old standard mobile crisis will be paid at the regular H2011 rate of $39 per 15 minutes. MCIS will pay at with the HE modifier at $105.57 per 15 minutes. Now, here's one difference from the last time you may have seen a draft of the billing guidance. In prior versions, when we talked about billing for old mobile crisis, we were talking about just billing with H2011 and no additional modifier. We decided it was important to differentiate mobile crisis services from general crisis intervention services where H2011 might be used. That's why we've added in the CG modifier. It's not a pricing modifier because the rate is the same as if you bill H2011 without CG. So it's really operating as an informational modifier so that we know when you bill H2011 CG, it's a mobile crisis and not a non-mobile sort of crisis intervention. So that's a difference there. But yeah, and then HE is the modifier that's the pricing modifier that will get you that $105 rate for MCIS. And if there are no questions at this time, we can move to the next slide. Okay, so, and Brian, it's funny, I wasn't sure if the version of the slideshow that I sent you would update automatically, but it didn't. This is one, I actually just changed this particular slide in my version because this again was pulled kind of verbatim from the billing guide, and I realized it's not quite accurate as written. This is one thing that I'm going to go back and change. So as you see this, I'll read what's on my slide and see if you can track the difference. Or I'll just highlight what the difference is right here. Oh, still there. You can just leave it here, Brian.
Oh, yeah, okay.
That's fine. Yeah, I haven't updated it in the billing guide yet. It's just in the version of the slideshow that I have. I was thinking it would auto update your version, but that's fine. All right. So it currently says MCIS must be rendered by an MCIT or mobile crisis intervention team as described in the rules, whether providing the initial crisis response or a follow-up response. That is not exactly true in that the way I have it written right now, it says the initial crisis response must be rendered by an MCIT. You'll see in rule and in the billing guide, we do allow for one-person follow-up responses that are not rendered by a mobile crisis intervention team. The difference is what is required for follow-up is that it's only an MCIT response for follow-up that will be paid at that HE rate of $105 per 57 minutes. So follow-up responses can be rendered by a team or by one person, but it's only those team responses that are paid at that HE rate of $105 per 57 minutes. I will get into a little more detail on that a little later, but I just wanted to clarify that because this particular slide I realize is really in contradiction with later in the guide where we talk about allowing that. So, and the other point made here is that MCIS can only be billed by providers that have been certified for MCIS and have had it added to their certificate of approval. You all should have heard from our licensing and certification department on that process. So hopefully that's something you're well aware of by way of next steps to take and how to get that done. Next slide then, Brian. Okay, another just kind of core piece of, sorry, I'm going to just, when we talk reimbursement rates, Brian, can you go back to the reimbursement rate slide real quick? I apologize to y'all for the errors here and bouncing around a little bit. One more up, I believe. The text here that's written, I think I skipped over, but I wanted to highlight it because this was a question in our prior learning collaborative session. And it says these reimbursement rates are based on the service rendered rather than the number of providers rendering the service. So old standard mobile crisis is not fundamentally a team service. It can be rendered by one person or more, and that's fine. MCIS, on the other hand, especially when we're talking that initial crisis response, is fundamentally envisioned as a team service. So whether it's MCIS or the old standard mobile crisis that's rendered, you're only going to submit one claim rather than one claim per team member. If you have 4 people out there rendering the response, it's one claim. So the number of claims will not change based on number of providers or team members, but based on the service rendered. And now, Brian, we can jump back to the 72-hour window slide. So another just kind of core piece about MCIS is that it can only be rendered for up to 72 hours from the beginning of the initial crisis response. Here's another piece that wasn't as clear as it needed to be earlier. So this is a new definition of initial crisis response, which wasn't in rule or guidance previously. So we define initial crisis response as when an MCIT responds to an individual experiencing a behavioral health crisis from the time the MCIT arrives on scene or first makes contact with the individual, whichever is earlier, until the MCIT leaves the scene. So that time period is the initial crisis response, and the 72-hour window starts when that initial response begins. Another question that y'all had, and this again gets more toward the programmatic side, but it's highly relevant for billing, is when does that 72-hour window begin again if there's another crisis? And whether you're in hour 50 of that 72-hour window or whether it's 3 weeks later, if at any point it's determined that another MCIT response is needed to de-escalate and stabilize the individual's behavioral health crisis, and this might likely could potentially come through another call to 988 or your county crisis lines, the 72-hour window will begin again with that additional initial crisis response. So anyways, even within that original 72-hour period, if there's another initial crisis response needed, that 72-hour window will begin again. I see we've got a hand up, Elizabeth, if you want to unmute yourself and jump in.
Thank you, Luke. I apologize, but so the HE modifier, going back to your follow-up page previous, it can only be delivered by a team of people. It's not just the original MCIT initial response by certified organization.
Can you repeat that? I wasn't fully tracking the question.
So on your original set that I received to build on, they had a code. It was the initial crisis response. It says use H2011 with the HE modifier, add HT when HE modifier has been used, and the mobile crisis team providing the in-person crisis response includes a QMHP. It has to take place, the HT has to take place outside of a hospital or facility setting. So in order to add the HT, so as long as a QMHP is responding to the primary service, you would use the HT and then, or the HE. Oh, is it a Monday today?
Yep. And I do have a slide on that.
If it's outside of a setting, then it would be an HT addition. Is that still correct? Or CG is confusing me. What would we use CG for now? If we're a certified MCIT organization, why wouldn't we bill everything out as AG?
Yep. Those are good questions. I do have a slide, but we just haven't gotten to it yet on like the specific billing for that kind of initial crisis or general MCIS situation. So I'll get to the HT piece in a minute. CG is really going to be in that we know that not everyone is, no providers are certified yet. I know it's going to take some time. So CG would be the only, you wouldn't use HE until certified, obviously. So CG would be what you would use to bill fee for service in the meantime. And then we also want to allow for the fact that there may be situations where even a certified provider might not meet the criteria in rule for MCIS, like say staffing, and you don't have a team that day available and you've got to send one person. That would be a CG. You'd use CG instead of HE to bill that. And then when I get to the follow-up response, there's a piece where CG will be a part of your regular billing, or could potentially be a part of your regular billing for follow-up responses. So again, I will get to some of these as we continue on. Beth, I haven't been tracking with the chat at all, but I did see
Yeah,
you're getting an email out with documents.
we're working on it. Of course,
Okay.
it's a Monday, like somebody
Yeah.
said. So all of the options to post and click and email are not working correctly. So we are working on getting the documents out, which are updated version of what you all were just referencing. But there is a question in the chat box right now from Tammy. Does the time of the visit start when the team arrives on site for billing purposes? So does the clock start when they get there or when they leave the office? It says the team might be interacting with others and perhaps not the individual in crisis. So is it when they arrive on site?
Yeah, you'll see here on the slide that we're looking at right now, it says for the initial crisis response begins when they arrive on scene or first make contact with the individual, whichever is earlier. That, in my mind, allows for what's envisioned kind of in the crisis now model of the warm handoff between, say, someone that's called 988 and the mobile crisis team. So, you know, envision someone on the way, a mobile crisis team on the way to the crisis location, talking on the phone with the hotline staff and perhaps the individual. And I do think it would, and there's another question in our FAQ that kind of addresses when you're working with, not with the individual themselves, but with other relevant people to the crisis, and how that works really. So it could be, you might be on the phone with the parent of the child and with the hotline staff while you're driving there, and that would meet the same criteria of making contact with, again, I see the gap in the definition here since it says contact with the individual. I think we can translate that to contact with de-escalating and stabilizing the crisis, even if you haven't actually arrived on scene yet. Does that answer the question sufficiently?
Yeah, so well, just for clarification, because it does sound like there's more than one option for this. So if they are speaking on the phone en route to the individual in crisis, or say a concerned person who's on site, if the team is talking to that person, they can start, the time would start as soon as they start that interaction while they're driving there. So the site is not a physical location in all cases, is that correct?
Yeah, I mean, the site is a physical location, you know, wherever the individual in crisis is, but the crisis intervention can begin before the team has gotten there, if that makes sense. So
yes, and then I guess the other clarification, and this might be, you know, if we can always get back to them if need be. So if they're talking to 988 and the 988 is updating them on the situation and the location and what's going on, but that conversation lasts 15 minutes and then they hang up and then they drive there, which pieces of that would prompt the billing?
yeah, I mean, I think you've started the initial crisis response as soon as you have engaged with the crisis, in that if the MCIT is talking with the hotline staff, that one I may have to think on a little bit.
Okay,
If it's just talking with the hotline staff and not with the individual or someone sort of in crisis with the individual, family, bystander that called, something like that. I think that would not be billable. But again, I can circle back to that one. And if whoever asked that question can maybe drop it in the chat as clearly as possible, that'll help us get a good answer to it.
Yeah, I'm going to update. I'll put into the chat box because I sort of summarized a few different things in there. So I'll summarize and then we can get back to them on that one.
Gotcha.
Elizabeth, your hand's still up, but so is Jen. So Elizabeth, I don't know if you have another follow-up. No. Okay. So Jen, go ahead.
I appreciate you following up on this particular question, is what is the billable time allowed? Because the rate conversations that we've been having with the CCOs are incredibly dependent on how you answer this question. Our assumptions have been this is only face-to-face time with the person of concern, just as would be true on behavioral health counseling or other sorts of procedures. So if it includes other input, like a mental health assessment might include collateral review of documentation and et cetera, that is a big deal. And we really want to make sure we're in alignment with exactly what OHA and CMS think here, because it has a pretty significant impact on the amount of time that's going to be counted towards mobile crisis versus other crisis, and it's going to have a significant impact on those discussions that we've been having, like with Lauren and other folks, on what's up with how the actuaries are anticipating cost for the CCO. So not let alone the fee for service cost to the OHP fee for service. So it's a big one.
Thanks, Jen. And I just dropped the question and answer from our FAQ document in there, which says into the chat says, is non-client facing time spent making referrals and coordinating care billable? And the answer is yes, if the individual is engaged as appropriate and services are documented correctly. That's specific to some of those follow-up services like referrals, care coordination, things that are required and part of the service, and that is envisioned as something that may not be happening with, again, as any other time you'd be doing those sorts of things. The individual has to be appropriately engaged or apprised. But yeah, there's no that would be considered billable time. The other piece where I could see it in like a mobile crisis, like in one of those initial crisis responses, is that the individual, I guess actually I have another question here. I'm going to drop the other one in the chat that addresses this, just so I have the language from the FAQ.
Thanks. It really is knowing what nature of those things where you're not directly with the client work. Transportation, yes or no. The contacts with those other key folks, yes or no. Referrals, yes or no. All of those sort of what goes in and what goes out matters. Thanks.
Yep. So this other one I dropped in, I'll just read it again if anyone else is not looking at the chat, but it says, during a crisis intervention, the MCIT will spend time with the individual in crisis, but may also need to speak to family members, law enforcement, or others present at the scene to gather information and stabilize the situation appropriately. Is the entire time spent on scene rendering the service billable? And does billing change if the individual cannot be found or engaged? So the answer is yes. The entire time spent on scene, engaging with family members, law enforcement, others present at the scene, is billable to the extent the individual is engaged as appropriate, services and everything's documented. If the individual, like say you show up, I know this is an example that has been raised a few different times, you show up to the scene where the individual was reported to be in crisis and you cannot find them, or they are unwilling to engage. In that situation, just because Medicaid billing is dependent on an individual being a Medicaid member, that is a situation. I do have some questions in with some of our policy folks just to see if there's any wiggle room there, but the current understanding is that if the individual cannot be found or engaged at all, then Medicaid would not be able to be billed in that situation. I know I see there's some action in the chat. Beth, are any of those questions that
I think it's just I was just putting a couple statements in there to clarify some of the questions that are coming up around when billing is covered. I think that you covered the questions around if a family member or a neighbor calls and they're engaging and getting collateral information about what's going on, that can count as the beginning of the time, assuming that they then are able to make connection with the person who of concern. And then someone just asked though, what happens if the individual is not Medicaid? So for what is the process? So we're talking right now, can you just explain that to them a little bit about the billing process?
Yeah, in terms of, well, yeah, so this is all, I mean, what I'm addressing here is Medicaid fee-for-service billing guidance. If the individual does not have Medicaid, I think generally commercial insurance does not cover these sorts of crisis intervention services. So, and I also know that has been part of the conversation with rate setting, with CCO rates of what does it look like to appropriately fund the entire system when not every response is going to be billable to Medicaid. Thanks, Beth. Yeah, those service element funds. Yeah.
Yeah, so of course, there's a lot of costs incurred by this process, like Jen was saying. So when you can bill OHP, we want you to bill OHP as often as possible for OHP members, but we also have funds included in Service Element 25 and 25A that also can be used to offset some of those costs, although I understand that's a whole nother debate or conversation that's happening.
Yeah. All right, shall we move to the next slide then?
Luke, can
Or
you,
got-
is all of this guidance just for open card, or are the CCOs following this guidance as well? Is the next question in there. So to clarify, when
Yeah.
you're speaking, are you speaking of all Medicaid or just open card?
Yeah, so I can tell you when this guide is published, it will refer to it as a fee-for-service billing guide only for fee-for-service members. But part of the, if for those of you that have been involved in the CCO rate setting process, they're working on setting up a risk corridor to identify both MCIS, new standard mobile crisis rendered, and old standard to make sure all that works together. And the intent is that I think it's not going to be immediate, but as of January 1, 2024, all Medicaid billing will follow this guide. So billing for CCO members will be the same. And the intent is if you bill for any Medicaid member in the same way, it's simpler. So you're not having to deal with different methods, whether they're open card or belong to a CCO. And it will facilitate the kind of the encounter claiming documentation, everything supporting the risk corridor that's set up. So
one last question, Luke, before you move on, is if FQHCs should bill at their encounter rate, but H2011 is an excluded code under that. Can you speak to that?
I can, yeah. We're working on that. I have been in touch with the policy analysts that oversee that list of excluded rates for the PPS. Yeah, so the intent is that it not be excluded. That conversation, I've got Katie Rosenthal from the that works with CCBHCs, and I'm forgetting names right now, but yeah, that's on our radar. And we do intend to have those clinics that normally bill with a PPS rate to do that moving forward. So we'll sort that. All right, are we good to move to the next one, Beth? Thanks.
We are good, yes.
Go ahead, Brian. Okay, so and this is kind of like the core piece. This is the most important slide, if you will, as it relates to how you're going to bill MCIS. As we've already said, you'll use H2011 with the HE modifier. That's what gets you that $105 per 15-minute rate. That's the pricing modifier. We have an informational modifier that we need you to use when the following three criteria have been met, and this is the HT modifier. So if the HE modifier has been used and a QMHP participated in the duration of the response, and the response took place outside a hospital or facility setting, you'll add the HT modifier as well. That HT modifier, whether you use it or not, it's not going to change what you get paid. It just tells us that the response met the criteria for community-based mobile crisis intervention services from, this is section 9813 of the American Rescue Plan Act, that set out a particular level of service as community-based mobile crisis intervention services. So yeah, it's not going to impact your reimbursement rate, whether you apply this or not. But we do need you to use it when your response meets those criteria. Any questions before I move on? If not, Brian, let's go to the next one. Okay, and we've also added a definition here of follow-up response, because again, we've used those terms in the guide and elsewhere. We already defined initial crisis response, and now for a definition of follow-up response, it's just any MCIS rendered after the end of the initial crisis response is a follow-up response, and it's billed in exactly the same way as on the previous slide, H2011 HE, and then add the HT modifier if it applies. That's applicable when you respond with a team. And as I mentioned before, you can, under the new rule set, you can render follow-up responses with one person rather than a team. If you do a one-person response, follow-up response, you're going to bill it with H2011 CG, which I know we're calling that old standard mobile crisis, but really we're indicating it's mobile crisis paid at the regular H2011 rate, unless, and here's the sort of one caveat to all this, if the initial crisis response used the HE and HT modifiers, then a one-person response can use HE and bill at that higher rate. And then if the follow-up response took place outside a hospital or facility setting, you would also add HT. This is probably the most complicated little piece of the puzzle, is this exception where you can get the higher rate for some one-person responses. I do have, again, I don't know how many of you have actually had a chance to see the new billing guide, but there is an appendix at the end of that. That's really just kind of it's like a decision tree document. It asks questions that'll help you determine for the initial crisis response which modifiers to use, and same for the follow-up response to help you kind of walk through the criteria and which are relevant for determining which of these modifiers to use and when. We can show you that at the end if we have time, but that is designed to help you in the clearest possible way sort through which modifiers to use and when.
Luke,
Yeah,
there's a couple. If the team goes out and say the person is not wanting to meet with them or refuses to engage with them, but the team is able to assess them by observation and interactions as part of the assessment, right, is what you observe. Mm-hmm. And they're able to like come up with a plan maybe with people, if it's a family member. Is that considered, can they still bill, should they be billing for that under the person's Medicaid if they are not actually, but the person is refusing?
Mm-hmm. That is a good question. Kind of getting at that nuance that I know will be helpful for you all when you're actually out there.
And it might be something that we clinically look at, because a lot of people that I work with don't necessarily engage clinically, but that's part of the assessment. It's sort of their mood, their mental status, right. And these guys might. So my gut clinically is to say that yes, but I think that there's a lot of nuances to that question in situations where it's hard to just give a flat answer. But I would think that would be up to your clinical judgment around if it counted or not. The other thing too is, has it been determined if jail is a community-based setting?
Yeah, that's a good question. It's not included in the definition of a facility in what we heard from CMS, but it is not, like, carceral settings are not billable to Medicaid in general, aside from whether you're going to be using the HT modifier or not. Like, they're just, it's not just that you wouldn't use that HT modifier, you wouldn't bill at all for responses to a jail. That is something they're kind of looking at and tinkering with, if they can find a way to get that into a waiver where we could get Medicaid coverage for that, but that's a long ways out and not on the table right now. Other questions right at the moment?
Is the waiting room at the ED or booking room at jail considered the community? So before they're actually admitted, if they are en route or they're hanging out, or if the police call before they're actually booked and they want a mental status exam or some of these folks to come out and meet with the person. Thoughts on that, Luke?
Those are great questions. I would say, again, just I've worked more on the kind of hospital facility setting piece than on the jail piece, just because the jail is kind of not billable at all right now. So, but again, we'll certainly come back to that one and maybe add it to the list to get clarity on. But the waiting room at the ED, that's at a hospital. I would be inclined to apply the same. The jail one is a little different because it's not, the issue is not so much the location, but about whether or not someone loses Medicaid eligibility while incarcerated. So that one has nuance that's a little more complicated than just where the response goes to, if that makes sense. But I do feel confident saying the waiting room at the emergency department would not be considered for the, you would not use the HT modifier in that case.
And Luke, we can talk more about that piece as well, because some of these guys are contracted with their emergency rooms to go in, and they are the behavioral health team. And so I think maybe that's where that's coming from, is typically. And so when is that a different job or a different sort of contract than what we're asking them to do through this billing guidance with the community-based response? So we'll just leave it. So Tammy, let us stir on that a little bit and make sure it's clear, the difference between those two.
And I will also say that for the purpose of rules, we did not define community-based in the same way that CMS does. So we just said community-based is like the location of the individual, and we do want you to go to where the individual is to provide the service. We will pay the higher rate when you go serve someone in an ED, but the state will not get the enhanced match for it, which is what when you apply the HT modifier, that's what triggers the state to claim the enhanced match for CMS's defined community-based mobile crisis intervention services. So again, it's not going to impact your reimbursement for that particular response if it is in an ED.
So just to clarify, Luke, if they're admitted into a jail or they're that they're already arrested and in jail, then often they lose their benefits for Medicaid, which would mean we can't bill them. So if they're currently in, we will look and see about the booking and pre-admission. But you just said that in the waiting room at the ED, they can bill for the enhanced rate. Is that what you just said?
Yeah, the higher rate is available. Yeah. So HE, billing the HE modifier has nothing to do with whether you respond in a hospital or facility setting, but it would determine whether or not you can use HT.
Thank you. I think that clarifies the question.
And we will follow up on the question about the booking room at the jail. All right, I think we can go to the next slide. All right, here's just kind of your basic information on billing old standard mobile crisis. So again, this is going to be relevant until you're certified to bill MCIS, or if at some point after you're certified, you're not rendering MCIS according to rule. For whatever reason, you're going to bill H2011 with the CG modifier, and you would never use CG along with HE or HT. Those two modifier groups are kind of mutually exclusive on the same claim. And then this list of things, eligibility criteria to be eligible for payment under H2011, that's just from the Medicaid state plan. These are really things that are supposed to be true across the board for crisis services. But I've got them listed here. And if there are no questions, we could go to the next one. All right, so a bit about place of service codes, and this applies to all mobile crisis services that you're rendering. We want you to use place of service code 15, which indicates a mobile unit. That's really kind of from the frame of reference of like where you are rendering the service from, as opposed to the location that you've gone to. So if you go to a hospital to render the service, we still want you to use, the mobile unit code, because you're indicating we are coming to deliver the service. The difference here, and the only sort of exception, is if there's other guidance that requires you to use a different place of service code. And the only example that I'm currently aware of is with telehealth claims. Telehealth rules currently require you to bill telehealth claims using the O2 place of service code. So in that case, you would use that place of service code instead. And there's a note here: if the MCIT uses one or more telehealth service modalities during the response, in addition to the in-person response, you'll have to bill each of those service modalities as a separate line on the claim, because there are different place of service code and modifier requirements depending on the modality. If we get to some examples at the end, some scenarios, I can give you some examples of that. There's also a scenario in the FAQ document that kind of identifies what that would look like. Questions, Beth, or are we ready to move?
Nope, we're ready to move, and we're still working on the email addresses and things to get the documents
Yeah,
out.
I really apologize to all of you that we didn't have these for you to look at while we're working through it. Thought it would work to just drop them in the chat here and attach them. So I know that's a challenge. Okay, this is, I feel like stabilization services is this piece that it's easy to lose when we're talking about the new 309.072 rules. It is not just part of MCIS. It is a separate but closely related service, especially when you're thinking of serving children and their families. MCIS and stabilization services combined is what we refer to as MRSS, or Mobile Response and Stabilization Services. And Beth is our resident expert on that. I'm sure you are all well aware of and working with her toward getting that stood up. In terms of billing, and there are some changes here compared to prior drafts, but again, get certified so that you can bill for these services. And the basic framework here is that if additional services are needed after the end of the 72-hour period in which you can render MCIS, and again, that period includes both the initial and follow-up responses. If there's more services needed after that 72-hour window, then you should bill for stabilization services. And the way you'll do that is on the next slide, Brian. So the basic kind of framework for billing stabilization services is just to use the appropriate outpatient procedure codes from the behavioral health fee schedule for the services that you render. And this is based on the way it's set up in rule, which has you on sort of entry into stabilization services, taking the individual through a mental health assessment, creating a service plan, and then again, rendering services according to that plan. We heard from several of you that that was going to be a challenge in getting that mental health assessment done, always sort of within that 72-hour or 3-day window from the start of the crisis. So we've got a bit of flexibility here now. The way it's written up here in the billing guide is if there's a delay in completing the mental health assessment and service plan required to bill most outpatient codes, medically necessary and appropriate stabilization services must still be provided. And in this case, you should bill using H2011. But you must also complete the required mental health assessment and service plan as soon as possible. When you're billing, and again, if we think about H2011, it's crisis intervention services per 15 minutes. It's not unique or limited to mobile crisis intervention. But when we're talking stabilization services, we are now out of the realm of HE, HT, or CG. Those modifiers are all only for mobile crisis. So if you do end up billing H2011 for stabilization services, it would just be H2011 by itself. It would just be sort of crisis intervention services, except, and the one additional informational modifier we need you to use with stabilization services is TS for stabilization services that are rendered to youth and their families. If you use H2011 and you're providing stabilization services to a child and their family, it's going to be H2011 TS. If you have gone through, if you were able to get the normal intake process done and get the mental health assessment and service plan, and you're rendering, and then you're billing the outpatient procedure codes, you would apply the TS modifier to every one of those services rendered. And that's just going to help us sort of identify everything that's claimed as stabilization services rendered to youth and their families. Questions on this piece?
Oops, yep. So Tammy has a good question, is how long would you apply the TS modifier? And so ideally it all happens pretty quickly, but we do know that sometimes families aren't available or things happen. So the TS modifier can be for how long?
Yeah, so, and this is clear in rule, the stabilization services period can extend up to 56 days. So that's really the window for applying that. The intent would be that during that 56-day window that you have to continue rendering stabilization services, that you're going to identify what ongoing services folks need and get them sort of transitioned into a regular outpatient.
Oh, and thank you. And Luke, just to clarify too, just so you guys, so 56 days is the average, but we do have a clause in there that when it's clinically indicated, you all can stay on with a family if we feel like they're at risk of re-escalating, if you need to wait longer than 56 days for their appointment or something like that. So we do have a little bit of a clause in there. Jen?
A quick question here, and I had this confusion before. So when the peer on the MRSS team is doing that work, the peers don't bill H2011. A's can and P's can, but not peers. So what does that look like?
Yeah, Luke, you actually updated the SPA to include peers from what right? Sorry, go ahead.
Yeah, peer, yeah, according to the SPA that was approved, peers can bill, or you know, they are considered an eligible provider to bill for stabilization services. So if that's an issue of just the way peer billing generally works, I think we're assuming that like the billing provider in these cases is going to be the CMHP, as opposed to the individual provider rendering the service. But yeah, like, so for instance, support stabilization services could be rendered, Beth, and correct me if I'm wrong, by a family support specialist. I don't know. I know it's supposed to be a team, but I can't recall if there's like a team supposed to work together on it or if they actually have to deliver it together every time.
No, so my understanding, and Jen, Luke and I might have to coordinate the answer to this. But my understanding was that the SPA was updated and that peers were added as being able to bill for that 2011. And so that was no longer an issue. When we did the OARs, we had put outpatient in there so that when they have their mental health assessment, they could choose family support specialist or peer delivered services so that they could then bill under the treatment plan. So I'm not sure if that addresses it exactly, but we do have peers are able to provide services individually under a service plan. That was the thinking, at least before the SPA got approved.
And I will say the same would be true even with MCIS, in that you might have a peer support specialist doing one-person follow-up. And that's, and it could even bill with the HE modifier and HT and get paid at that higher rate, providing the initial response met those criteria that lead you to that situation. But I don't know if this is where the confusion stems from, but I did have a question from someone about the fact that H2011 isn't listed on the behavioral health fee schedule under the peer delivered services tab. And that is the case, it's not listed there. Just by way of clarification, that tab on the behavioral health fee schedule doesn't indicate every procedure code that a peer can bill. It actually only indicates those that have a different rate than what's listed somewhere else on the fee schedule. So H2011, for instance, it's listed under the outpatient services tab, but in the rendering providers field, you'll see peer support specialists listed. So they are eligible to bill that code. It's just that the rate is not different. The peer support, the peer delivered services tab indicates when there's a rate differential based on it being billed by a peer compared to a different provider. Other questions?
We'll look into that, Elizabeth, because we did a lot of work behind the scenes to make sure that peers could be included in this with the new SPA. So let me investigate that, and I might shoot you an email too.
And Elizabeth, if you're willing to clarify, is that only if the peer we're trying to bill as the billing provider, or is the same thing apply if the CMHP is the billing provider and the peer is, for instance, rendering the service according to the plan or something along those lines? And we can dig into it later if that's simpler too.
Are you asking Elizabeth?
I was, but that I may not have made that clear. And it's definitely something we can circle back to and just tie up with our teams. So I know we had actually reached out to our peer team at OHA and just need to get the dots connected with the right people to clarify.
Can you, Elizabeth didn't hear the original question. Do you just want to repeat it really quick? And Elizabeth, don't feel like you have to answer it if we don't know. We'll do some investigating. But I think the long story short is that we changed the SPA to include peers under H2011. So if there's something in certification or something somewhere else that we need to know about, Luke, that's what you're asking, correct?
Yeah. I just saw Elizabeth's comment in the chat that says credentialing causes the peers to be able to bill crisis services. And I was just trying to clarify, is that mean, or is your understanding that they cannot bill it at all, or would it only apply if they were billing as the billing provider? And is there any difference if the CMHP is the billing provider, just billing with the peer being the rendering provider? And again, okay, can't bill it at all. All right, well, that's something for us to solve because according to the state plan, they can. And if there's something internal, either in rule or somewhere else or somewhere, we'll get it solved. So.
We'll follow up on that. That seems like that might be a bigger issue, and hopefully we can resolve that. But thank you, Elizabeth, for bringing that up. And then also just a huge call out. Thank you to everyone who's putting their email addresses into the chat box. Again, we're having major issues behind the scenes. If you do want the 2 documents that I cannot attach into the chat box right now, if you would like us to email those, I do need you to put your email into the chat box for us. And we are behind the scenes trying to send an email out to you all. So please put your email address in there if you'd like the copy of the 2 documents.
And we also will get them published on the website
exactly
soon as well.
Luke, will this recording also, someone wanted to know, will this recording also be available to them to watch later?
Yeah, that's the intent. We're recording it. And
yep.
I say
we just wanted to double check that it would be available. Okay.
Yeah, the intent is that it be available. Shall we go? I'm lost track of my own spot in the PowerPoint to see what comes next here. And are there any other questions, Beth?
Yeah. Angela, do you want to, the fee schedule, so someone's just quoting the fee schedule. The fee schedule says H2011, $39 for 15 minutes. GT, and then it says certified peer support wellness is included. So maybe they're just showing that. That's the old rate. So just know, or that's the original rate. We do have a new rate if the 2-person team meets the new requirements, correct?
Yeah, that's correct. And under both lines, there's a line for each rate on the fee schedule. Peer support specialists are listed as appropriate and eligible rendering providers.
Correct.
Both of those lines, yeah.
And then just one last clarification for Tammy, a young person that is fully enrolled in outpatient services. So say somebody already has an outpatient therapist and they call 988 and a mobile crisis team goes out. Would they be billing after the 72 hours for stabilization services, even though the person's already enrolled in outpatient?
That's a great question. And it's actually one, I don't know if it was you, Tammy, in a prior setting or someone else, but we have gotten that question and gotten an answer in the FAQ document. So I'm going to drop that in. But the short answer is it depends on whether you just continue to render the outpatient services you were already rendering, or if you say something new happened in this individual's or this child's life, and now we are, what's the intent and scope of the services that are being rendered.
Right. And I mean, a clinical, and we're trying to we can also talk about this in the learning collaborative too, and go through some examples, because I would think you would probably do some case management to try to get the person reattached with their outpatient provider. And if it's not, if they're not wanting to do that and need a different service, you might then enroll them in stabilization services to reassess, and if they need a different level of care or a different treatment plan in place to connect them. So.
Yeah, and it's also the case that stabilization services are not just outpatient services.
Right.
There's a process outlined in the rule that has to be gone through to engage a child in stabilization services. So it's essentially that's going to determine the answer there.
Mm-hmm. Thank you.
The benefit to the state, Tammy, is information. This helps us differentiate stabilization services rendered to children and their families from any other outpatient services rendered, or if it's billed with H2011 from other crisis intervention services. And this billing guidance won't apply to private insurance. So if you're billing a private insurer, I don't know that you would use, you would follow whatever guidance they have for you. That is actually kind of the end of the presentation. That is just kind of summarizing the billing guide. I have a couple of billing scenarios I could show you if we continue through the presentation. The other option, and I'll leave it up to you all, would be we could walk through the frequently asked questions document just so you can see the questions that are already there. And we may have time for both because we still have another half hour. Am I right on that? Yeah.
Correct. You have until 11:30, so you have 30 minutes.
Well, let's try these billing scenarios real quick. And then, but again, I want to give you all as much time as you need to ask questions and to sit with this. And again, I know this is not as useful as it would have been had you all had these documents in front of you. So yeah, Brian, why don't we go to the billing scenario, the next slide. And Beth, thanks for your help working these up. I am not going to read that to you just because you've heard me talk a lot, but I'll let you look at it for just a minute. And if anybody wants to take a stab at how to code that one, I'd love to hear that. But And maybe the first question I'll ask, rather than having anybody just try to code it correctly, would be, first question would be, does this initial crisis response qualify for the HE modifier? I see Elizabeth shaking her head no. Why would you say that, Elizabeth? If you're willing, to answer, sorry, I shouldn't just be.
I'm willing to throw myself out there.
Yeah.
I was under the impression it had to be a QMHP or a member of the approved MCIS team. Is that wrong?
It's partially wrong, and I should have clarified here, I guess, which type of team we're talking here. So yeah, I did have in mind here a provider that is certified for MCIS, should have specified that. And I am thinking of trained MCIT team members. So in these scenarios, I'm assuming that everything is operating according to rule. So the one difference, though, is to use the HE modifier, a QMHP does not have to be part of the response. QMHP, according to rule, a QMHP has to be available if they are needed, but they do not have to actively engage in the response for you all to bill at the higher rate. So this particular response, you would be able to use the HE modifier and be paid the $105 per 15 minutes. So go ahead, Beth, did you have something?
No, I was just going to clarify. So because the QMHA and peer support specialists are trained in part, and you guys are a certified team, all they have to do is have access to a QMHP who's trained in order to get the higher rate. And then someone in the chat box said, why wouldn't we have the QMHP bill as an assessment at that point in time? Because there's a code 90907, I forget, whatever, for a mental health assessment, which is typically a higher rate. But they would they use that then, or would they continue to use H2011 and have that QMHP would bill $105 per 15 minutes for however long it would take to do the mental health assessment?
Mm-hmm.
Which one is the way, how would they do it?
Yep. And if you all have had enough chances to look at this, I think, Brian, the next slide shows how I have it set up to bill. This is the one that I used the example of, so it maybe not have been the best one to start with, but this is the one where you have to bill multiple lines because it involved telehealth and in person. But to your question, Beth, if the QMHP that's available to the MCIT is needed, and they do have to call them in, which happens in this response, right? Like they show up, or no, let's see. I have to go back to or look at my own example real quick. Yeah, they work with the individual for 30 minutes, determine that a mental health assessment by a QMHP is needed. They contact that on-call QMHP who completes an assessment via synchronous audio video with the individual the last 45 minutes. That QMHP is rendering MCIS at that point, okay? They're not, while what they're doing is an assessment, the assessment is part of the service array of MCIS, and they have just been added on as the third member of the MCIT that's responding to this particular crisis. You will not, when the MCIT is rendering MCIS, which is anytime in that 72-hour window, you will not bill other codes that may reflect the specific service that's being rendered. So the way it would be billed here, we'd have H2011HE with 2 units, place of service code 15, just indicating mobile unit. That's their initial response on site. You've got 3 units on another line with place of service code 02. This indicates that it's telehealth. And then you have the GT modifier added, which again, this comes from telehealth. It's when you're doing synchronous audio video. But again, still paid at the H2011HE rate. And then when the QMHP is done with the assessment and it's just back to the 2-person team on the ground, you have 4 more units of H2011HE with a 15 place of service code. I see a question from Debbie, if you want to jump in.
Yeah, in this particular scenario, I understand the 2011 from the scenario, the H2011 with the HE modifier with the QMHA, but they also contacted a QMHP who participated in the service. Yet you're telling us that when they participate in the service, even though the HT is not a pricing modifier, it's to be used when a QMHP has participated in the response, whether in person and or via telehealth. So why wouldn't the HT be on that first line?
Yeah, that's a great question. I am gonna, Brian, I don't want you to have to like bounce around too far, but I'm gonna just go to, or you, Brian, if you want to, you could scroll all the way back up to slide 6, which says when to use HT. And there's one thing you missed, Debbie, I think, which is you can only use HT when a QMHP participated in the duration of the response. And this was a key piece from CMS. They said if it's only going to qualify for as community-based mobile crisis intervention services when one of the team members that's qualified to do an assessment, which in our world is a QMHP, is engaged in the entire in the duration of the crisis response, as opposed to being available on call, getting on the phone to do the assessment, and then going off. That one is not going to qualify to use HT.
Great. Okay, thanks. I missed the duration of that piece.
Yep.
So Luke, just to clarify, because there's a couple questions on the same sort of category. So if a QMHP is one of the first responders that's on site as part of the 2-person team, is that when you would use the HT?
It depends on if they're there for the duration of the response. If they're there for 15 minutes or even an hour and they leave while the team continues to work, you would not use HT. That QMHP, to use the HT modifier, they're going to have to be there for the duration of the response.
So if 3 people show up to the site, we have 3 people that get there and one of those person is a QMHP. How do they bill and who bills for the time there? Because they're used to the QMHP rates being higher. We, under the new rate, we have this $105 rate that is that rate to try to cover some of these other costs, like having a QMHP on call. So the rate is higher, but they're used to having the QMHP do.
Yeah, so and this goes back to one of the statements on a statement on one of the slides. I don't recall which I think it's on the reimbursement rate slide, which just says if a team provides the service, whether MCIS or old standard mobile crisis, only one claim may be submitted rather than one per team member. That would be the same regardless of the size of the team. If you send 4 people out, you're going to bill H2011 HE, assuming you meet all the criteria for that, one time. So you would not have a 3-person team like a QMHA and a peer billing H2011 HE and then the QMHP billing separately, because the QMHP is there rendering MCIS, and MCIS can only be billed with H2011 HE, and it's only billed once per team or once per service rendered, as opposed to billing on an individual basis. And really this comes down to, MCIS is not just one service. It's a whole service array that wraps in everything that's needed to stabilize an individual, that might be needed to stabilize the individual crisis.
So the question here, and Tammy, I think that it's just hard. It's sometimes hard to transfer these things clinically into the billing, like that crosswalk from thinking about it clinically to thinking about how to bill Medicaid is hard. So she's hearing that a QMHP responds via phone, they can bill, but if they're on site, that they're not billing. And so that's not necessarily true, but Luke, do you want to explain sort of the difference in those two?
Yeah. Well, if a QMHP responds via phone, and I don't know if this is your exact scenario, Tammy, if QMHP responds via phone as part of the mobile crisis intervention service, MCIS is billed at, according to this guide, H2011 HE, $105.57 per 15 minutes. The QMHP's response is part of the service and the rate that you get paid for that is $105. So it's, again, and really this comes down to if you have a QMHP available on call. If you have a QMHP available on call, you are in effect, and that QMHP engages, you then have a 3-person team, as opposed to a 2-person team.
Yeah,
So
I think,
the rules do require that you always send 2 people when you're rendering MCIS in person. So again, as you work out your staffing models, it's just recognizing if we choose to have our QMHPs available on call, in some cases, that means we'll have 3 staff members engaged in one crisis response, potentially on a regular basis, depending on how often that's clinically indicated.
so I think the confusing part, because we got Angela here who added a statement too, is that you're talking about billing lines and having 3 billing lines. And they're talking about who writes the progress notes, which is the clinical person who's on site has to write a note, right? So if a peer and a QMHA and a QMHP go out to a site for an hour, or not, sorry, if a QMHA and a peer go out for an hour, they're going to write a progress note for that hour and bill the 4 15-minute increments, but then say that QMHP then gets called in to do an assessment. The QMHP has to be the one to document their assessment. So I think that it's confusing because we talk sort of clinical language and who's doing the progress note. So Tammy, I would think that in your example, if the QMHP is going to probably always document their intervention themselves for the amount of time it took, you guys can decide if the QMHP is there for the entire duration, do they bill for the whole time from beginning to end and include their mental health assessment? Or do you guys want the QMHA to do the first hour, then the QMHP, then it depends on your EMRs and how you guys clinically are doing things. I think that that's what you guys are getting at in there. But if anyone wants to unmute, Angela, Mary, Tammy, any of you guys want to unmute and verbalize your question?
Hi, Beth. This is Tammy.
Hey.
Oh, I'm sorry, Angela.
Can I have Brian go back down to just because I know somebody wanted to see the scenario again. If you can just drop back down to that one. Thanks, Brian.
Right there. Whoops. So can we go forward one slide? So on here, the QMHP that was called up on the phone, it appears that that person gets to bill 3 units for the 45 minutes they spent on the phone. But if the QMHP would have gone in person, then they wouldn't be able to bill for that. It's like,
No.
if part of it's by phone.
Yeah, so the difference here, Timmy, is that
Or do all of those add up to the total duration?
yeah, exactly.
Oh,
All of those
sorry.
So yeah, when the QMHP
Okay.
is, anytime there's telehealth involved, the telehealth like modifiers in place of service
Right.
codes sort of
Okay.
take precedence over any other ones. So yeah, that's
Okay.
that's also not only representing the QMHP's time on the phone with the individual, but also the time that the other 2 members of the team are there facilitating and talking with other individuals. So,
Okay. I'm sorry. I thought because it was all separated out. I didn't do the math. Sorry about that.
no worries.
Yeah, so I think I'm doing my math now, Tammy. I think it ends up being like for the first day, you're billing 3, 4, 5, 9 units of it. So 9 15-minute segments at $105 rather than that $439.99 if you have a qualifying team, which adds up. So that's to cover some of that extra costs of having the QMHP and all of the things that we're doing.
I guess for me, my biggest question, when the P is involved, it's not as complicated to me if they're on site the whole time, because then you're just going to have the highest credentialed person write the whole note, right? And they're going to document the whole time. So that makes sense to me. It's when it's like this. This is when it gets more complicated from an EHR perspective, because I'm looking at how am I going to make that billing happen and the documentation correlate to that without having to make people document the same thing repeatedly, right? So what I'm seeing is like they would have the I think it was an A and a peer that arrived on scene first, they would have to write 2 notes, even though it's one interaction in their eyes, it's one interaction, because you're saying that I need to split out the time, because they can't bill for that the time that the P was involved, right? So I've got to be able to take that time out and say, you can't bill for this time because the P is going to be billing for this O2 telehealth time. So they kind of have to like split their note into, it's like, I'm on pause, I'm ending my service time, and now I need to document another note to bill my other service time once the P's done. So then it just makes it really complicated, because then I'm looking at my documentation and my EHR says anytime a crisis response happens, I need to gather all this crisis information of when did it start, when did I arrive on scene, all these different things, but I'm still within the same session, right? Like I'm just splitting after the P. So it just makes it really complicated from an EHR perspective of how am I going to get that to split all out and document and bill correctly. Does that make sense?
It does.
It totally
more to
does.
Beth than to me, because she has the clinical experience that I don't have. But yeah, it is complicated.
And I'm just looking at any like ideas of how in the world to make this, especially because we're looking at peers and QMHAs, we want to utilize those staff members. It's already hard when I'm telling them, you only do this when this, and there's so much stuff with this, we have to ask so many questions, that I'm now telling them, you can't bill for this chunk of time because now the P is going to be billing for it. What is required of me for that second note, that last 4 units of their follow-up? Can I create a different documentation that doesn't have all that crisis stuff involved in it, and it's just like a second interaction on a crisis response that's super basic? Like, what is going to be required when OHA comes out to audit this and looks at my documentation, so that I make sure that I have what I need for time rendered and the documentation to support that? That's what I'm asking, I guess.
Great questions, Angela, and I appreciate your attention to just trying to figure out how to do it the way that someone coming out to check will want to see it. I'm not sure to what extent, we'll have to get follow-up from those teams, just because I'm not a documentation expert and wouldn't know exactly what they'd be looking for. The way I've envisioned it, and again, not knowing how the different EHR systems differ, but would be like one set of documentation for the team, in a sense, as opposed to trying to cobble together the documentation from each individual provider. That obviously gets complicated if you have 2 people on site and a QMHP that's available via telehealth when they engage. But when I think of like what documentation they would want to see, it would be like a combination of the team, because even the team on the ground is going to know we called in, it was clinically indicated that we needed to call in our P. We did so, they did an assessment, it was 45 minutes. So in a sense, you could have that documentation so that the QMHP's documentation would be supporting that perhaps. So again, this is me just kind of thinking off the cuff of what it could look like, but I don't know that the agency obviously needs to be clear on like what the expectation is, but I don't know exactly how it would map to the different systems that you all have. So yeah, that's not an answer. I acknowledge that doesn't solve your problem, but we'll keep thinking through how to be as clear as we can about what the expectation is, and hopefully it's in a way that is as simple as possible for you all.
Yeah, what I would like to see is if it's okay. I mean, if it's obvious that timeline shows when an auditor comes out, that second, I could create a note that I can train our staff on for that second, the bottom line in this example, right? Not the follow-up, but the bottom to the initial response.
Right.
That I could just have a different note that's a super basic note that just like, what additional things did you do, and not have all that other mobile crisis required stuff that's like all that pieces of it, so that I would just train them like, okay, if you had somebody come on, like call in, right, then you're going to pause your note, you're going to stop your note, original note, that's all that. And then I'm just going to have this ancillary note that's pretty basic of like, what additional things did you do after that? And as long as it's okay, my question is just making sure that from an audit perspective, if I have a super basic note, is that going to be okay? And also then the end time, because part of the mobile crisis response timelines of everything you have to ask is, when was the end of it, right? So it asks, when did you arrive? When did you first contact somebody? And then when did you end? So it's going to be weird because I don't want the QMHP to say an end time, right? Because then my documentation for times aren't going to be correct, because that person basically isn't going to answer any of those questions because he arrived after the fact of initial contact with the client, and then there's still contact with the client afterwards. So he needs to not do any time, that person, not he, whoever, that person needs to not document any time, but then I need to have two notes to separate so that my EHR system can make sure I'm not double billing times, right?
Yep.
So it's just super complicated in this type of scenario. When a P's on site the whole time, it's easy, like easy peasy, good deal. Like that person does it, we're good. It's when you're pulling that person in that gets more confusing. And then the other question was, if it's phone only, if they don't do virtual telehealth, then are we not billing? Like, would then it just be the QMHA and peer doing it, and there'd be no
Yeah,
additional phone?
phone is billable under current telehealth rules. So it would just be, instead of the only difference in billing would be the GT modifier would not apply, because that is the one that indicates the synchronous audio video. I also will indicate or mention that I know that there are some telehealth rule changes, either I can't recall where they're at in the process, but they're working on some changes, and there's a chance that the modifier place of service code requirements change, such that there might not be the requirement to bill to do multiple lines. I know that would simplify things. I have no idea if that's actually on the table with their changes, but I do know that there are some telehealth changes in the works.
This is Teresa with Lincoln County. I am in total agreement with Angela and the complications that this may cause. One thing that I would suggest, just based on the folks that are on the ground and their documentation versus the QMHP that's via telehealth, is that they would continue documenting in that one. They would document a start and stop time, and then another start and stop time, to be able to capture their total time separate from the QMHP. We actually have an internal use code set up for our providers when they perform more than one service within a billable encounter, so that they can have those separated start and stop times. So that's a suggestion as well.
Thanks, Teresa. And are you suggesting that like the team that's on the ground, the QMHA and the peer, the stop time, they would indicate that they're stopping their service while the QMHP
Pausing
pausing
their service. So start and stop time for the first 30 minutes, and then start time and end time for the last hour, so that captures those two separate place of service 15 line items there, and then have the QMHP document. Is it expected that all of these are going to be on one claim?
I think that would be I'll say that's been my assumption, that something like this, that's like one initial crisis encounter, would come in on one claim. But I would be curious, and this is again where I have gaps in my knowledge.
Well,
as Beth said, like, I was
sorry.
gonna say, Beth indicated one claim, or I've been thinking one claim per encounter. But
As Angela kind of explained a little bit, in our scenario, or the way I would envision our scenario would be the QMHP would be documenting in their own encounter, and the two that are on the ground, the QMHA would be the documenter for that particular situation. So in our EHR, there's no way for those two to combine. It would be actually a very manual process to combine them into one claim.
Okay.
And attempting to get different places of service for different line items on one claim is darn near impossible, unless we're sitting there writing out claims by hand.
Okay. And it sounds like you don't want to do that. And I don't want you to have to do that.
I'm sure you guys don't want to have paper claims.
Yeah. And another, just as you mentioned, based on what you just said, and also what you said earlier about the start and stop, from someone who, if there's anyone on the ground who has the kind of real clinical experience of doing mobile crisis work, and again, I don't know how viable this scenario is, but my assumption has been that you might have, say, the QMHA working, like when the QMHP via telehealth is doing the assessment, and I don't know if the QMHA would be there facilitating the conversation, however that assessment is happening, but the peer might also continue to be talking with a parent, for instance, and doing real crisis intervention work while the assessment is happening. It's in my mind, it's not as if that work stops necessarily while the assessment is happening. So again, at least in my mind, like all of the work that is done would be documented. And again, I had imagined it all rolling up into one claim that represents what happened in the crisis intervention. I see that we're almost out of time. Angela and Teresa, you've been really helpful in just helping me see some of the complication here, and especially around what it would look like to separate it out into more than one claim, especially if that would simplify the billing. So I'll certainly go back and review the recording on this, but if you're willing to take any time to like write up in an email or just something to kind of like in a clear, succinct way articulate both the challenge this presents as well as like what suggestions you have that might make it more workable, would super appreciate that. I think we're down to like 1 minute left. I had another scenario here that's actually a simpler one. I'm sorry I didn't start with that because I would have just showed without the multiple lines. Yeah, I don't want to take more time than you all allocated for this. We are going to have another session next Tuesday. It was really designed to be 2 duplicate sessions. So for folks who couldn't make it to this one, but I don't know how many additional people there will be. Feel free to come back to that one if you want to go through additional questions, especially if you've been able to see the documents by that point. Since we're out of time, I'll just say thank you so much for being here. Thank you for the work that you're doing to support standing up this important service for our communities. And yeah, it's an honor to try to get this right with all of you. So thank you. And feel free to send, as we email out the docs, we'll make sure you all have my contact information to be in touch moving forward. Thanks.